For having such a long lecture after a first test. I apologize, but unfortunately that's the way the food crumbles. Today we're going to talk about the esophagus, stomach, and small bowel. Okay, some of this is going to be reviewed from your GI class you had last semester. Okay, but we'll get through. Okay. All right. So these are the diagnoses and stuff that we were going to talk about. There's a lot more in the esophagus and stomach, but there's like 10 things for small bowel and what could actually cause a small bowel obstruction. So we'll get through it. All right. So review. Everybody remembers from anatomy the different layers of the esophagus when comparing to the bowel wall. Biggest type of difference is within the esophagus you have the longitudinal muscle layer as well as the circular muscle layer. Okay, you still have the serosa and mucosa. In the esophagus you have the intestinal villi that helps kind of move things down. Within the bowel wall, I would know like mucosa is inside, serosa is outside, and then the layers in between when you go to phase 2. Okay. When you have a enterotomy, you go all the way through serosa to mucosa into the lumen, okay? But if you only have a serosal tear, that's different. It doesn't go all the way into the lumen. You still have to close it, but it's not as detrimental to the patient unless it goes all the way through. Okay, so knowing the layers is kind of important in surgery. Okay, when we talk about blood vessels, around the gut, around the stomach, okay? All of these are pretty important because when you do surgery on the stomach, on the duodenum, the spleen, these are the types of things that we always have to keep in the back of our mind as to what it's supposed to look like and be aware of variants of those. Okay, so off of the aorta, right past the diaphragm, we have the celiac trunk, which then branches off to the left gastric. You have the common hepatic and then the splenic. Off the splenic, you have the left gastroepoic artery coming down. Off the common hepatic, you have the right gastroepoic coming down, and that does the greater curvature of the stomach. Okay. The left gastric comes down and does the lesser curvature of the stomach, as well as you have the right hepatic artery coming off of the proper hepatic artery. Okay, I'm not going to make you know all of them. Okay, these are the major ones that when you go to the OR, your phase 2 preceptors, your surgeons are going to be really impressed if you know kind of a roundabout like where these are, what they branch off from. Okay, so just review. All right, review important arteries to the intestines. We talked about this during our acute abdomen. Okay, I'm not going to go over them. Again, not going to go over them, but this is just review. Okay, we did not talk about the veins yet, though. When you think about the veins, the venous structures of the abdomen is a little different, right? You have the vein, inferior vena cava, that runs along the spine. Okay, but you have the portal vein. The portal vein is the main junction of all the other venous structures. Okay. Kind of other than the renals, which are a little weird, but everything else, the spleen, the stomach, all converges onto the portal vein, goes through the liver, gets filtered, and then goes into the inferior vena cava. Okay, so if you have a liver problem, you may have a venous problem, which if you look off of here, right, so if you have a liver problem, you have a portal vein, you have the coronary vein. This is not the same thing as a heart vein. It's just called coronary. Okay? But if you have a backup in your liver and that is putting pressure on the portal vein, it's going to put pressure on the coronary veins, and these gastroesophageal collaterals are where you get your esophageal varices from. Okay? So that's why when you have somebody who has a really bad cirrhosis, really bad liver failure, you can bleed into the esophagus because you have those varices. Okay, so knowing the anatomy is super important. Okay. All right. Moving on to anatomy of the esophagus. Like we talked about, 2 muscular layers, an outer longitudinal, inner circular. The esophagus is made up of three different parts, basically, based on location. We have the cervical, which is 5 centimeters long, it's striated muscle. Then we have the mediastinum, which is 20 centimeters long. Okay, the striated muscle is replaced by smooth muscle, which when you have muscular disorders or nerve disorders, this is why why you have difficulty with getting food down from those motility disorders. Okay, and then the last little part is 2 centimeters in the abdominal cavity past the diaphragm. Okay, so it just depends on where it is in location. We already talked about the esophageal branches of the coronary vein, which can lead to portal hypertension, which can then lead to varices. Okay. All right. GERD. You all learned about GERD and GI. Okay. This is just review. The stuff highlighted or underlined are the stuff that is more important than, commonly 18 to 27% of adult males or adult human or Americans. Okay. But symptomatic GERD, we have 80% of them will have a hiatal hernia, which we'll talk about in a minute. Okay, so what are the signs of GERD? There's two different types of GERD. There's esophageal and extraesophageal. So extraesophageal, you'll have, it's further down or up, depending on where it is. So if it's really, other way around. Esophageal is down, extraesophageal is up. In terms of cervical, think extraesophageal. If it's mediastinal or abdominal GERD, then it's more esophageal. You'll have the heartburn, you'll have the dysphagia, the chest pain, the regurgitation, versus if it's higher up in the cervical esophagus, you're going to have that cough, that hoarseness, that bitter taste, that globulous pharyngitis, or not pharyngitis. Basically, it's that feeling that there's something back there that you can't swallow, and any dental disease. Okay. When we think about worrisome complications, weight loss, progressive dysphagia, gastrointestinal bleeding, vomiting, all of these, if you have GERD-like symptoms plus these, automatically you need to start worrying about malignancy. Okay, which we'll talk about. All right, so you already learned about the medical treatment of GERD in your GI class. So what happens when that PPI doesn't work? Then you send them to general surgery or GI. Okay. What we do is basically we have to figure out where the problem is and has it progressed to something else that's bad, like Barrett's esophagus. Okay, is H. pylori present? Is there a motility disorder present? Is there a hiatal hernia present? Okay, so the first thing we do is pH testing. It's our gold standard. Okay, we basically do an endoscopy, an EGD. We go down, we put a little tiny pH monitor that kind of clips to the skin right above the esophageal junction, okay, the esophageal sphincter, and it basically tests that pH for like 24 hours, and then it comes loose, and then it goes through the GI tract and out. Okay. So if they have a positive PI test, we know that they have GERD. We may also need to do, like I said, that upper endoscopy looking for erosions and ulcers. We need to take biopsies when we do that EGD. Okay, confirm whether it's Barrett's, whether it's corrosive esophagitis, whether it's something else that's causing that GERD. Okay, and then knowing their history, if we find a peptic stricture, okay, or webbing, then we need to figure out why. Is it because of malignancy? Is it because they, drank bleach as a kid? Like, what type of things could have been caused, or what could have caused those strictures/webbing? Okay. Thorough pre-op workup is required for anybody that has refractory symptoms. Okay. This chart, I would know because it's really good, especially for your general surgery rotations. Basically, it's empirical treatment to PPI, response no, increase to BID PPI, response no. Then we got to figure it out, and then we got to do surgical intervention as to why. Okay? If it's Barrett, that's a different treatment than if it's just an incompetent lower esophageal sphincter. Okay? So medical management, you guys can read all that. It's just review. I'm not going to go over it. But failure of failure of PPIs and/or H2 blockers, or if symptoms return after stopping those PPIs. So failure means it didn't work at all. 8 weeks, they still had symptoms, or it worked, but after 8 weeks, the symptoms returned. We have to do that EGD. We got to probably do esophageal it's a Monday. Not going to be able to say it today. Basically, it's checking to see if that muscle is actually working. Okay, I apologize, I can't say that word today. But does the LES actually work? Is it working correctly? Is it too tight? Is it too loose? Is it not opening when it's supposed to? Whatever. Okay? Then that ambulatory 24-hour pH testing, that gold standard for treatment. Okay? What happens if it's just GERD because the LES isn't working right? Our best treatment is laparoscopic Nissen fundoplication. Okay? Basically what we do is we go in laparoscopically, that's with the cameras. Okay, we can do this open, but most of the time we don't anymore. And what we do is we isolate the esophagus, we find the diaphragmatic opening, foramen, where the esophagus comes out. We tighten that so that it keeps the stomach down. Okay, we try not to over tighten it because then we can cause obstruction. But then we take the cardia and we actually wrap it around and, you know, basically suture it in front. Okay, so we're basically making another LES. We're tightening it. Okay, most of the time it's a 360 wrap, meaning we take it from one side, wrap all the way around, and tack it to where we took it. We could do only a 180. Okay, taking it from the back and just, you know, lightly tightening it. Okay, just depends on how bad their symptoms are, how tight it is in there. And then we'll talk about the LINX magnetic band when we talk about hernias. But LINX is basically a magnetic band that sits right above the cardia, underneath the diaphragm, and is just a, think of those magnetic stones that kind of just attach to themselves. They kind of move, but it opens and closes as food comes down. So it's a foreign body kind of thing that we put in there to help close that sphincter down. Okay? All right, moving on to gyrus diverticulum. Again, you've already learned this, but just to review, symptoms: dysphagia, halitosis, throat discomfort, palpable mass, and then regurgitation of undigested food. That's the biggest thing, regurgitation of undigested food. Okay? Recurrent aspiration pneumonia, you should always be thinking about this. Okay? First test, barium swallow. Okay? We are not thinking of that it is a perforation, they're not sick, they're just uncomfy. Okay? So barium swallow is perfectly fine. This will actually delineate the size. This is going to tell us where the diverticulum is, the position of it. Okay? And this is one of the ones that, like, an EGD is not recommended as the first assessment. Okay? If we don't know where it is, we don't know how big it is, we could actually perforate it by adding air to it. Okay. So this is one of the only ones that an EGD is not recommended as the initial assessment. We have to do that barium swallow to prevent perforation. Okay. We may do an EGD afterwards after we know the size, location, but most of the time once we find it on this swallow study, which you can see here, okay, so that little outpouching up here is the diverticulum off the esophagus. Okay. So yeah, Killian's triangle. This is where it normally is at, right above the cricopharyngeus muscle. Okay. Surgical treatment. Treatment is surgical. Okay. We can't really get away from it, especially if they're having discomfort, regurgitation of food, chronic aspiration pneumonia. They have to get rid of it. Okay, so what we do kind of like a side approach, and we isolate the diverticulum. Basically, we cut longitudinally into the esophagus, pull out the diverticulum, and this is called a stapler. Okay, the type of stapler. I'm not going to make you remember, but it's basically a linear stapler. And what that does is it clamps staples at the same time. There are some that have a cutting function on it, but not the linear one. So with the linear one, you clamp it and it staples, it fires staples through it from both sides, okay? And then you can sharply dissect or sharply cut the diverticulum off right next to that staple line, and we suture our cut up, our incision back up the posterior esophagus, and then we move on. Okay, most of the time it does not cause any real complications. Okay, prognosis is excellent, very rare complications, and normally they can eat the day after the procedure. Okay. All right, so we have a 36-year-old female presents to the primary care clinic complaining of 3-month history of chest discomfort. She describes substernal, worsened by meal, or discomfort that is substernal, worsened by meals, sometimes nocturnal, denies weight loss, and ordonia sure. She is currently taking 40 mils of omeprazole daily for GERD. That was diagnosed 9 weeks ago. Her medical history is not contributory of physical exam without abnormality, which is probably the most appropriate next step in managing this patient. Who wants 1? Who wants 2? 3, 4, 5. Good. Okay. So, yes, we want an EGD. Do we want to refer them to general surgery to get this EGD done? Yes. Okay. Yes. So, but it's not emergent. Just a routine referral to general surgery. Words matter. Okay. So yes. So we want an EGD, but we're going to refer them to general surgery to do it. Just not emergently. What's that? Absolutely. Yep. GI also does them, so it's a constant struggle on who wants to do them. But if it's most of the time, if it's something that will likely need to go to surgery to do, like to actually definitively fix the issue, it'll just go to general surgery, and we will do the actual EGD. Okay. Achalasia. Again, I actually read through your GI slides, so I know you talked about this. Okay? Remember, bird's beak, okay? Sometimes caused by Chagas disease, sometimes caused by viruses. Basically, it's a motility disorder of the esophagus, okay? Leading to a functional obstruction because it's not actually moving things down. It's just chronically kind of stuck in this contracted type of state. Okay, dysphagia is the most common symptom. Aspiration pneumonia is also common. Carcinoma is also common from prolonged exposure to that acidic material. Okay, differential diagnoses, things to think about: that benign strictures, GERD, carcinoma. Okay. So diagnosis. What do we got to do first? So endoscopy is normally done to normally performed first to rule out obstruction. Okay? So this is different from Zankers, right? Zankers, you can actually eat, you can get things down, but you're actually just regurgitating food. Versus with achalasia, you have an obstruction. There's nothing getting past, meaning they can't eat, they can barely swallow, so they're having a lot of pain with eating. Okay? So we do that that endoscopy to first rule out obstruction, and then we do the barium swallow to actually see that pathognomonic bird's beak. Okay? We have to make sure that there's nothing actually in there, like food or whatever, causing that obstruction, and then we can do that bird's beak to see that that pathognomonic bird's beak, okay, or the barium swallow to see that sign. Okay, esophageal. Oh, there's that word again. Mammography. Yep. Sorry, guys. Yep. So checking to see the strength of the muscle contraction. Okay, is the gold standard of diagnosis. Okay, lack of peristalsis, absent relaxation of the LES is a diagnosis. Okay. Okay, we also have, I'm not going to make you guys know these, but the Eckert score and the Chicago classification are things that we help, or that helps us kind of identify. So Eckert score is really to identify the clinical severity, okay, versus Chicago classifications divides it into the subtypes. Again, just know that they exist. Treatment, there is no cure. Unfortunately, there is no cure. It's really just palliative stuff that we can do for symptom relief. You have the medical treatments there, but we're talking surgery. So our first treatment options are endoscopy, which we do. We can intercenteric injections of Botox. Okay, so going down all the way to the LES if we can get there, and actually inject the LES with Botox to help relax it. We can stick a balloon down through the strictured area or the diseased area and try to dilate it. Okay, and then there's the perioral endoscopic myotomy. Basically, what that is to go into the it's endoscopically. We basically cut into the muscle through the inside of the esophagus. Okay, it's not all the way through the serosa, but it's through that longitudinal or circular muscle. Okay, to help open that up. Okay. Other surgical options is the laparoscopic hilar myotomy with a 180-degree anterior fundoplication. Okay, not going to make you know what that is. Okay, but basically what it is we go laparoscopically. We basically cut into the muscle but from the outside, and then we use it kind of like that Nissen fundoplication. But it's we grab the muscle and kind of bring it around to redo the LES. Okay. Last resort is actually to remove the diseased portion of the esophagus with esophagectomy, okay? And then bring up either, so say it's like the last part of the esophagus, we'll actually bring up the stomach into the chest and attach it to the non-diseased part of the esophagus, or all the way up depending on how bad it is, okay? It really is, we try not to do that, but it's reserved for severe dysphagia and failure of all other treatments. So. All right, solid foreign bodies. This happens a lot. Most can just pass spontaneously. Okay, most, or 10 to 20% need to be removed endoscopically. 1 to 5% require surgery. Okay. Could be anything. Pediatrics, coin, button batteries. Do not miss these. Okay. If you suspect or a parent suspects a coin or a button battery, they go to the ER. Okay, and you call the ER and you tell them, hey, I have a kiddo with a button battery in their esophagus. Then the endoscope will most likely be already in the ER. Okay. Fish bones. Ooh. Fish bones is another one. if the patient's last history, excuse me. The patient's last meal included fish, and they're now having dysphagia. Okay, you need to kind of consider fish bones. If left, if undiagnosed, these will erode through the esophagus and cause perforations. Okay, fish bones are dangerous. Okay. All right. So, what do we do to diagnose? We do first we do an X-ray. Okay, we try to figure out where it is, if it's radio-opaque, if it's not. Okay, these are the types of areas in which we look if we can't find it. But most of the time, most things that people swallow are radio-opaque, and we can see them on X-ray. Okay. All right, treatment most of the time is EGD. Okay. Unless it's, you know, if you take serial X-rays. You'll learn in your EMED class. You take serial X-rays and it's moving through the digestive tract, you just let it go. But when it doesn't move, and or it's a button battery or immediate or like an airway is compromised, okay, EGD is the primary choice of treatment. Okay. One thing to remember, like I said, clinical observation, if the object is blunt and short, so less than 6 centimeters, and narrow, less than 2 centimeters, then we can theoretically maybe do some clinical observation. They're not going home, okay? They're staying in the ED. We're doing serial x-rays, either chest x-rays or KUBs or abdominal series, depending on, just to follow it through. Okay? The only exceptions are coins and button batteries or any type of battery, which we'll talk about. Okay. So, we want to remove it promptly to prevent complications. Like I said, sharp pointed objects, glass, fish bones, objects lodged for more than 24 hours or unknown duration will perforate. Okay, it will cause ulcers, it will cause bleeding, it will cause that to move and migrate through the esophagus. The esophagus does not like things sitting in it for very long. Okay. Disc and button batteries causes a liquefaction necrosis. So basically it attacks the wall of the esophagus, stomach, wherever it's at, and it will actually liquefy it. Okay, it'll kill the tissue, liquefy it, and then it'll perforate. Okay, this happens very, very quickly. Okay, the acid in our esophagus kind of attacks the battery, and then the battery attacks us. It's not good. Okay, some other general considerations. Clinical manifestations is really influenced by the site of perforation. Okay, so if it's up in the upper esophagus, you may have dysphagia, you may have a cough. Okay, you might have that globulous sensation. Okay, if it's lower mediastinum, you may have that substernal pain. You may have chest pain. You may have, mediastinal type pain. Okay. And then, depending on whether or not that mediastinal pleura has been ruptured, you might actually have, so if it's up in the neck, you may have subacute air in the neck above the clavicles. If it's lower mediastinum, you may actually have pneumomediastinum. Okay? It really just depends on where the rupture is. Okay? If the time, so if it's been 24 hours or more since the injury, since the perforation, we are going to already be prepared for severe contamination and probably a lot of complications. Okay? Basically, it's not the perforation that kills you, it's the infection. Okay? Alright. If you have a patient who, again, has just gone through a esophageal procedure, an EGD, a scope, anything that put air into the esophagus, you have to always think of perforation. Okay, if they come in with severe, pain, dysphagia, it may even be shocking depending on where the perforation is, how long it's been. But you'll kind of get that sense that they are sick, okay? If you know, then you have to kind of always assume that it's perforated, which then we do what type of contrasted study? If we think the esophagus is perforated? The water soluble ones, right? The iohexol, the gastrografin. We do not do barium if we think that it is perforated. Okay. So surgical repair techniques will really depend on where the site is that is actually perforated. Okay. All right. Say it is a spontaneous perforation. We didn't do it. Okay. So Boer-Haave syndrome. Okay. This is the absence of any pre-existing esophageal disease. Okay, normally we see this with, after a bout of heavy eating and drinking, they have a lot of retching, a lot of vomiting. That causes that intraluminal pressure to be excessive and ends up tearing a hole into the esophagus. Okay, so it's not necessarily spontaneous. There's a reason, that's retching, but it's not caused by any other pre-existing esophageal disease. Okay, the primary principal manifestation is pain. Okay, and most likely will radiate to the back. like I was saying before, that cervical perforation, okay? You have that pain that's followed by crepitus or that subacute emphysema, dysphagia, signs of infection. If it's a thoracic perforation, you're going to have tachycardia, tachypnea, dyspnea, and the early development of hypotension, okay? If it's bad enough, you can even cause a pneumothorax. You can have a hydrothorax, but it's not necessarily blood. It's like saliva and all this grossness, and then it can cause an empyema, okay? Because NCCPA and the PANCE loves to throw in nice little signs and words. Mediastinal crunch. Has anybody heard that before? Mediastinal crunch. Okay, so say you have a pneumomediastinum, so air around the heart, okay? When the heart beats against that air, and you listen to it, you'll actually hear a mediastinal crunch. It's basically that sub-Q air that you feel, but you're listening to it as the heart beats against it. I've never heard it, okay? But, so it's a mediastinal crunch, but it's also the Hammond sign. Okay, so if you have a pneumomediastinum, and you listen to that air, you listen to the heartbeat, you most likely will hear that mediastinal crunch, that Rice Krispies as the heart beats against that air. Okay. All right, how do we diagnose it? First we do the x-rays, okay? Then we do an esophagram with water-soluble contrast. Okay. We do it promptly for every patient that we suspect a spontaneous perforation, okay? If we do not see a leak, then we can repeat using a barium. Okay. And as a last resort, we can do a CT of the chest, abdomen, pelvis, maybe not pelvis, but chest, abdomen to kind of figure out where, neck and chest and abdomen to localize where this perforation could be. Or if it's not a perforation, because both the water-soluble swallow study as well as the barium swallow study doesn't prove a leak, then we can kind of do a CT scan to figure out what else it could be. Okay? We can do a thoracentesis, which is sticking a needle into the pleural cavity, into the chest, okay, to see what type of fluid we get. We can send that off. The amylase will be elevated. Serum amylase levels may be elevated, but the actual fluid that we pull off will not just be like normal pleural fluid. It's going to be perennial, and it's going to be cloudy. It's going to be gross. Okay. All right, so what do we do to treat it? We put them on broad-spectrum antibiotics immediately. Okay. This is normally polymicrobial. What antibiotics do you think we would do? What's your first thought?
Right.
Not bank. Nope. So what type of organ is the esophagus?
Yeah.
It's GI, right? If you have any other perforations in the GI tract, what are your antibiotics? I heard it. Flagyl, metronidazole, Cipro. We would probably also add on Zosyn. They would probably be on a three cocktail. But given that it is a polymicrobial gut, if it's perforated, ciproflagyl is one of the things we will most likely put up. Okay. They like to operate before it's 24 years old. Okay. 24 hours old, 9 years. Jesus. Who didn't catch that? All right. So basically, the sooner we can close that perforation and lay some drains for external drainage, the better. Okay. If we get them to the OR within 24 hours of it actually perforating, their risk or their rate of like actually making through it is upwards of 90%. Okay. After that 24-hour mark, if it's delayed by any reason, their survival rate drops to about 50. Okay. Mediastinal sepsis is not fun to treat. It is very painful. It can kill a patient pretty quickly. Okay, so this is, if we think that it's perforated, or we know it's perforated, say this guy, you know, comes in and he, you know, has that history of retching, vomiting, he's vomiting blood, he has that mediastinum, or that neck subacute air, right? Or he has a pneumomediastinum on a chest x-ray. Most of the time, we may not actually get that barium swallow, or we may not even get that swallow study. They're just going to go straight to the OR. Okay? Because their life is, basically that, even though it may be the gold standard, we're still going to try to get them to the OR as quickly as possible because their clinical symptoms actually point to a perforation. Okay? If we don't know, then yes, we will do additional studies. But if their symptoms really point to a perforation, then we are going to just go straight to the OR. Okay? Other esophageal injuries, Mallory Weiss tears, you've already learned about these. Okay? Basically, they're lineal mucosa tears. Okay? So it doesn't go all the way through, just the mucosa. Not much to do in terms of treatment. Most of the times they go, will stop bleeding by themselves. If we need to, we can do endoscopy to inject the Mallory Weiss tear with a sclerosing agent to help it stop bleeding. Okay, but most of the time we don't really necessarily need to do anything as long as they stop bleeding. Okay, as long as we can keep them from vomiting and stop the bleeding, most of the time they heal on their own. Okay, if the bleeding is substantial or persists, that's when we do the endoscopy to do the injection, clipping, banding, and or anticoagulation of the actual lesion itself. Alright, we have a patient with a history of alcoholism. Reports vomiting bright red blood after several hours of vomiting and retching. He presents to the emergency department with chest pain, low-grade fever, nausea. Which of the following physical findings most strongly suggest he has a rupture of the esophagus? Okay, who wants 1, 2, 3, 4, 5? Is everybody paying attention? Everybody awake? So, most strongly suggests a rupture, that's subcutaneous emphysema. Okay? Alright, leading into corrosive esophagitis, just further into esophageal injuries, okay? Biggest thing is acid leads to coagulation necrosis, which actually leads to an eschar formation, okay? Ultimately, it really limits the ability of that acid to get through the rest of the tissue. Okay, so once you have that eschar, that dead tissue, okay, most of the time that acid can't get through. Alkaline agents, unfortunately, lead to liquefaction necrosis, okay? Far more commonly ingested, found in household cleaners like bleach, and will likely lead to a frank perforation. Okay, doesn't have that eschar formation to stop that erosion. It just goes straight through. Okay. Signs and symptoms: dysphagia, drooling, mouth burns, abdomen, chest pain. Okay, fever, tachycardia, shock if it's perforated. You may have subcutaneous emphysema if it's perforated. On chest x-ray, you may see pneumothorax, you may see effusions, you may see pneumoperitoneum. You may see pneumomediastinum as well. Okay. What do? Consult GI for possible EGD. Really, it's fluid resuscitation and supportive care. Do not make them vomit. Okay? Do not stick any NG tubes down. Do not blindly neutralize the chemical. Okay? Perforation and instability mandates surgical exploration and resection. So people who drink bleach, okay, they perforate, they basically go straight to the OR for washout and removal of whatever section of the esophagus we need to. Okay, a lot of times we will leave drains. Sometimes we will actually leave a little fistula in which spit can actually come out, like, because if we leave any discontinuity, we'll leave part of the esophagus open to the neck or the chest. so that they can actually have an open end. Okay, it's pretty gnarly. I haven't seen too many of them. Okay, most will mature into strictures. Okay, once you damage the esophagus does not like to just go back to a nice normal fluid tube. Okay, it becomes very scarred down. Okay, strictures, webbing, and most will require those barium studies following, starting at 4 weeks following the initial injury. Okay, however frequent and for how long really depends on the extent of their injuries and their GI specialist. Okay. Most of these patients do not have satisfactory results. Okay. It's just a fact. We can't get them back to normal. Okay. Dysphagia, so chronic inflammation and scarring. We normally do a periodic EGD with biopsies because, again, anytime you damage the esophagus doesn't like it and will change its actual tissue type and into cancer. So we must always do esophageal or EGDs to check for esophageal cancers in people who have this history. Okay, speaking of carcinoma, the esophagus generally gets diagnosed between the ages of 50 and 70, most within the Asian, African, and Iranian type of populations. You have two different types, squamous cell carcinoma and adenocarcinoma. Okay, you learned about this in GI, so I won't go through it too much. But both types normally present at advanced age. Okay, a lot of people don't know that they have stuff going on until it's too late. Okay, early, asymptomatic. Okay, dysphagia is the most common symptom that they come in for. Okay, normally it's they can't tolerate solids, and then it progresses to liquids. They have weight loss. They have pain over bony structures from metastasis because of its advanced age. If it invades the recurrent laryngeal nerve, you'll have hoarseness. And then if it erodes into the trachea, you'll have a tracheoesophageal fistula, and then you'll have respiratory symptoms like chronic pneumonia, cough, just badness. Okay? So what do we do to diagnose? We have the endoscopy, which is the EGD, okay, direct visualization, and we can take biopsies of the tumor. We do the barium swallow to actually look for luminal type of disruptions, okay, or irregularities. And you can see it on this one up here, okay, and then here, just doesn't look right, okay. And then we also want to do bronchoscopy, which is the camera down the trachea and into the lungs, so that we can actually look for any tracheal involvement. So we want to do a CT of the chest and abdomen. Okay. We're looking for distant metastases. Okay. An invasion, we want to do a PET scan. The most sensitive test, though, is an endoscopic ultrasound. Okay. We'll do a EGD, which has an ultrasound probe at the end. It really helps us determine the depth of the tumor, invasion into other surrounding structures. Okay, and it allows for fine needle aspiration of lymph nodes when we see them. So most sensitive test, endoscopic, also known as an EUS, so endoscopic ultrasound. Okay. We also want to do a bone scan for any patients with new onset bone pain with a history of esophageal cancers, because it goes to the bones pretty regularly. Okay. All right, treatment really depends on the stage of the cancer. If it's really localized, we'll do neoadjuvant chemotherapy and radiation. We want to shrink that tumor as much as possible. And then we will do a esophagectomy, okay, which you'll see in this picture down here. Basically, we take the stomach, we take out the part of the diseased esophagus, and then we bring the stomach up into the chest. We basically kind of do like a sleeve, which we're not going to talk about today, the bariatric surgery. We kind of do a sleeve gastrectomy. Okay, we cut off part of the stomach to make it more into a tube, and then we put it up into the chest. Okay. If it's non-operative, we can more do palliative care, therapy. We can still do chemotherapy, neoadjuvant radiation. We can put a stent in over or through the tumor to try to open up that esophagus so that they can eat. Okay. Most important prognostic factors, basically the stage. Okay. 5-year survival rate remains around 25%. The earlier we find it, the better it is. But unfortunately, since most of the time we really don't notice, or patients don't come to see us until it's late in the game, the survival rate is just not great. So now we're going to go into the stomach, small bowel, okay? You have the stomach, you have the LES, where the esophagus comes down and meets the stomach, you have the cardia, the body, you have the pylorus with the pyloric sphincter, and the duodenum, okay? When we talk about the duodenum, there's 4 parts. There's 1, 2, 3, and then 4, okay? I'm not necessarily going to make you know that, but just know that retroperitoneally, you have the duodenum. Okay, so once the pylorus happens, then it kind of shoots retroperitoneally, okay, around the pancreas, which the pancreas is also retroperitoneal, okay. Then intraperitoneally, you have the jejunum and ileum, which is the rest of the small intestine, and then the duodenum and the jejunum is divided by the ligament of Treitz. Okay, when we run the bowel, okay, when we're doing an X-lab or we're looking for perforations or any disease within the intestines, we always try to find that ligament of Treitz first. Okay, it is where the intestine comes intraperitoneally. Okay, so it's basically end of duodenum and into the jejunum. Okay, where the jejunum starts, but it's intraperitoneally. Okay, it's a very big term within general surgery, so if you know it, you will impress. Okay. Alright. Hiatal hernias. Okay. 10% of the population will have a hiatal hernia, more than paraesophageal. So we have 2 different types. We have sliding hiatal hernias, which is type 1. Okay. And then we have type 2 through 4, which are paraesophageal hernias. Okay. Technically, they're all considered hiatal hernias because it goes through that foramen. Okay. But 1 is a sliding hiatal hernia, and 2 through 4 are paraesophageal. Right? So with 1, you basically have the first part of the stomach that slides through the esophageal foramen. Okay? It doesn't have a good position below the diaphragm. The diaphragm isn't tight enough, so the first part of the stomach just keeps sliding back and forth. Okay? Most common symptom is GERD, mostly associated with GERD. Okay, type 1s are the most common type of hernias, esophageal gastric hernias. Okay, type 2 through 4 less common, but basically it's either part of the stomach, so like the cardia comes up, so the LES is at the level of the diaphragm, but part of the stomach still slides up through that foramen. Type 3 is you have the LES is above, or that JE junction is above along with part of the cardia. Okay, and type 4 is you have the LES is above, you have part of the stomach above, and now you have other intestines or other organs up above the diaphragm through this one hole. Okay. If it goes through a different hole in the diaphragm, then it's not a hiatal or paraesophageal hernia. Okay, there's other types of diaphragmatic hernias which you may or may not get to, but these are the most important ones. Okay. All right. Many patients are asymptomatic. Okay, but when symptoms do occur, they really relate to what type of hernia they have. Okay. Type 1, you'll have heartburn, regurgitation. You have chest pain, dysphagia, epigastric pain, vomiting, postprandial fullness. You may even have anemia. Then it'll be the paraesophageal hernias. Okay, so what do we do to diagnose? We have the upright chest X-ray. We may actually reveal air level in the mediastinum. Okay, we do a barium swallow study to assess the portion of the JE junction as well as where Everything is kind of in relation to the diaphragm, okay? We still want to do an EGD. It is going to be difficult, especially with the higher grade type of periesophageal hernias, but we still want to do one to rule out cancer. Okay. All right, so what do? Gold standard is that laparoscopic Nissen fundoplication. So same treatment for GERD is the same treatment for hernias, okay? Like I said before, that LINX is a new minimally invasive procedure. It still has the ports, it still has the camera and everything, so it's not as minimally invasive as the laparoscopic. It's still a laparoscopic procedure, okay? But basically we have that LINX or that magnetic that we kind of sit, we pull everything back down, we put this LINX or basically this ring of magnets around the LES, okay, below the diaphragm. We tighten the diaphragmatic hole up so that it doesn't have a chance to go back up. Okay? It expands easily to allow food and stuff to pass through. All right, let's take 10. Come back at 11. Take some more time if you guys are good with that. Okay? All right, so now so we talked about hernias. Now we're going to go into ulcers. Okay? When we talk about gastric and duodenal ulcers, okay, the collective term is peptic ulcer. Okay? Lifetime incidence of PUD is 10%. Okay? Majority are caused by either H. pylori infection, a NSAID use, or some sort of hypersecretory acid state. Okay? All right. So within those two, gastric, food equals pain. Okay, this is the number one thing on how to differentiate between gastric and duodenal versus visualizing where they actually are. Okay, so if you have a patient comes in and they say, I'm losing weight because I can't eat, because every time I eat it causes me pain, okay, think gastric ulcers. Okay, for duodenal ulcers, okay, they're going to actually probably be the same weight. Okay, pain improves with food. Then, like, an hour to 3 hours after they've eaten, that's when their pain is. So when their stomach is empty, okay, that's when their pain worsens. Okay. And both feel better with antacid. So antacid use doesn't really help you in your differential diagnosis at all. Okay, that is a big thing. I would know this slide. All right, so what's one thing that actually can cause an ulcer? We have ZES, okay? This is not necessarily a disorder, but is an actual tumor, okay? It's a gastroma, okay? It's a type of tumor, normally near the pancreas, that produces excess gastrin, okay? Which then causes this syndrome, okay? Zollinger-Ellison syndrome. We're gonna call it ZES from now on. Okay, so you have ulcers refractory to treatment. Okay, you have ulcers in the distal duodenum or jejunum. Okay, and if you have recurrent ulcers despite treatment, most likely we have to look for a gastroma. Okay, in addition to doing EGDs and all this stuff, but we still have to look for that gastroma. Okay. So how do we do that? We look for the elevated fasting serum gastrin levels. Okay, fasting has to be fasting. They should not have eaten. Okay. And we want to stop their PPIs, antacids, H2 blockers, whatever they're using to try to relieve their reflux. We want to stop that 1 week prior to testing. Okay, it sucks. They're going to be miserable. Okay. If their gastrin level is borderline, then we can do a secretin provocative test. Okay. What do we do preoperatively? Okay. We want to do higher than normal doses of PPIs, and we really want to try to do imaging studies to localize the tumors. Okay. We can do somatostatin receptor scintigraphy. Okay, as a study of choice. Okay. What is the treatment? Remove the gastroma. Surgically remove the gastroma. Okay? If we do that and we remove that tumor that's causing these gastrin levels to be increased, then we can cure their DES. Okay? We do have to be careful, which is one of the reasons why we do imaging studies, is normally they may have more than one gastroma. Okay? So these people deserve follow-up. They may need additional testing, especially if they continue to have issues after the first one is gone. We may have missed one. Okay? All right. Moving on to just gastric ulcers. Okay? Endoscopy is the most accurate method of diagnosis. Okay? We have the clinical diagnosis just from what they say. Food equals pain. Okay? But we really have to see it in order to, diagnose it. Okay? Also provides opportunities for biopsies, test for H. pylori, we can test for malignancies. If it's bleeding, we can do therapeutic interventions. Okay? Multiple biopsies are indicated for all gastric ulcers. Okay? We're not just taking one little biopsy of the area. We may do multiple throughout the entire or lower esophagus to really rule out Barrett's. Okay? Limited value for lab tests, but we can do CBC to check for anemia. We can do a occult blood test, fecal occult blood test for bleeding within the stool. Okay? And then again, if we suspect that CES, a fasting serum gastrin level, may be useful. Okay? You all remember if it's positive for H. pylori of the triple therapy. Okay? Triple antibiotic, or 2 antibiotics plus a PPI for a minute. Okay, we may need to have them on a maintenance therapy of PPI for 6 weeks. We can do a urea breath test to confirm successful eradication. Okay. Say it's not H. pylori, and it's just hyperactive acid secretion. Okay, we can do endoscopic therapies, meaning depending on if it's bleeding or not. Okay. Really, that's thermal devices, so that's like the cauterizing of the blood vessel. We can do clips, we can do epinephrine injections to really try to stop the bleeding. If that doesn't work, we can go to IR. They can do angiography and embolization of whatever vessel is bleeding. Okay, and then definitive surgical management if it's perforated. Okay, anytime any ulcer is perforated, we go in. Just like if any of the other bowels are perforated, we go in. Same difference. Okay? If we have any hemodynamic instability, so they're in shock, they're septic, whatever, we need to get source control. If it rebleeds, okay? If endoscopic therapy and IR is unavailable, we're just going to go in and try to fix it. Okay, duodenal ulcers. Peak incidence 20 to 45. Because of H. pylori treatments and changing in NSAIDs, it's a little bit less to occur. Complications remain the same as gastric, perforation, and hemorrhage. Normally not associated with cancer though. Unlike gastric ulcers can be related to cancers, duodenal ulcers not so much. Okay? Alright, you have that burning, dull, gnawing epigastric pain. Right? No pain in the morning until hours after breakfast. So this is food equals better, and then after that food moves on into the through the duodenum, then you get better.
I was curious, is that pain localized to any specific area?
Pretty much epigastric.
Okay.
Yeah. Okay. What do? We do an EGD. We need to directly visualize the ulcer. Okay, again, just like gastric ulcers, maybe therapeutic depending on if it's bleeding or not. We want to do a barium swallow study if we do not think that is perforated. Okay, we're looking for that pool of barium in the ulcer bed. We can do what's called a maximum acid output. This is normally done by GI, so I'm not familiar with it. But it basically just does a gastric analysis. When we do the EGD, we can take samples of the gastric acid and kind of see what their acid levels are. Okay, and again, getting that fasting serum gastrin delivered DES. Okay, what are the complications? Pain, bleeding, perforation, and obstruction. Okay, the duodenal, or duodenum is, the first part of the small intestines. It's a tube. It can still obstruct if it's swollen, if it's perforated, not perforated, if it's swollen, if it's, has a big clot around it. Okay, this kind of just goes through the kind of sequelae of what happens. Okay, you have pain with an ulcer, but no bleeding or perforation yet. Okay, and then that bleeding erodes into a blood vessel, so then, or when that ulcer erodes into a blood vessel, then you have bleeding. Okay, you may have slick blood in the occult fecal, or you may have hematoemesis or melena, depending on where it's coming out of. Okay, and if it erodes even further, perforation, you have no blood vessels between, the ulcer and the outer wall, so no major bleeding, but you're going to have the pneumoperitoneum and or peritonitis. Okay? Okay, treatment. So if it's hemorrhaging, first thing is to resuscitate. We need to start an IV PPI. Okay? IV PPI, proton pump inhibitor. We will not use oral. Okay? This will be like high dose, 40 twice a day of an IV propanolol. Okay? We really don't do H2 blockers at this point. It's less effective. Okay? If we find H. pylori, we will start to treat. Most of the time the bleeding resolves spontaneously. Okay? If it's hemorrhaged and you don't have any signs or symptoms of perforation, then we try to do an EGD within the 24 hours so that we can try to stop the bleeding. Okay? If endoscopy fails, then we go to interventional radiology for the angio and embolization. If we think that it's perforated, okay, then it's surgery. We go to the OR. Okay, so if you have pneumoperitoneum, angio and embolization was not successful, you just keep having anemia and or hypovolemia, keeps rebleeding in the same hospitalization. We've given more than 3 units of packed red blood cells and or refractory to medical treatment. So it's been 12 weeks of medical therapy, and it just keeps happening, keeps getting worse. And or if we find CEFs, then it needs to go to surgery. Okay, similar to gastric ulcers. In terms of how we fix it, the next slide I'll kind of go through a little bit more. But the biggest thing is we can try to do a vagotomy. Okay, so sometimes the vagus nerve causes us to have too much of that acid-producing output. Okay, so we can actually cut the vagus nerve and reduce the acid production. Okay, we can. I've never seen one, but we can do it for gastric ulcers that just keep coming, and or any type of peptic ulcer, basically. If it's a duodenal or gastric, we can do a vagotomy if the symptoms just are not being relieved. Okay, so for bleeding ulcers, we need to ligate the blood vessels. We can do an enterectomy for gastric ulcers, so basically take the top of the antrum and just kind of get rid of it. Okay. Basically, a lot of the acid production is in the antrum. So if we take the antrum out, no more acid production. Okay. Pyroplasty, basically, depending on where we cut, closure of that defect is just from that. Okay. High-risk patients, really, so if we can do the ulcer excision with the truncal vagotomy, and the pyroplasty, basically it's reconstruction and resection. Okay, so we resect the part that's damaged, and then we reconstruct it with an anastomosis. Okay. There's a lot of different ways to reconfigure our gut. We'll go through that, I think, on the next page. Okay, for perforated ulcers, if you know this, the omentum or the Graham patch, your surgeon will be very happy with you. Okay. Basically, we take a little piece of the omentum that's still still attached to the other omentum. We bring up the omentum and basically sew around that defect from the outside. Okay. So upper GI surgery complications. If we do an aneurysectomy, well, we do have a little bit of a duodenal stump, so we can have leakage from that. We leave drains, but most of the time we do prompt reoperations. So they go back to the OR, we wash out, and then leave drains. If they have delayed gastric emptying, okay, after the gastrogenoscopy, wow, today is hard, sorry. Basically, we take out part of the jejunum and we put the jejunum up to the gastric. Okay, so we basically limit the duodenum altogether. Sometimes that can cause delayed gastric emptying. Most of the time it's medically managed. Okay? When we do the truncal vagotomy, we can have delayed gastric emptying, dumping syndrome, diarrhea, bile reflux. There's nothing we can do. We just, a lot of the times it's dietary changes, but this is part of that, informed consent, that these are parts of the risks that they may get if we do a vagotomy. Okay? If we take more than 60% of their stomach, smaller frequent meals, and then again, delayed gastric emptying if we have gastric emptying. If we have it may require prolonged gastric nasal gastric suctioning, we may need to start TPN, and we may need to put in a J tube in order to feed them, depending on how bad it is. Okay? So when I talk about resection and reconstruction, these are all the different types. Probably not all of them, okay? But it just depends on where and what gets reattached to what. Okay? I'm not necessarily going to require you to know these for my tests, but if you know these for phase 2, you will impress. Okay? Really, again, Billy Roth 1 and 2, it just depends on what part of the jejunum, okay, we are putting up into this, or attaching to the stomach. Okay? When we talk about root and why, it really depends again on what parts are reassigned, like where it actually reattaches. Okay? That is way above a primary care level. I'm not going to make you know those, just know that they exist. Okay. Dumping syndrome. This is something that you will see in primary care. Okay? You're going to have patients who have gone and had these things done, and they're going to come back to you and say, I'm having a lot of, palpitations, sweating, weakness, dyspnea, flushing, nausea, abdominal cramps, belching, vomiting, diarrhea. Sometimes they can faint, okay, really quickly after eating. And basically, it just means that where we did the surgery, okay, whatever we took out, the more we take out, the more likely they're going to have this, okay? Sometimes it's also called shortcut syndrome, okay? Basically, it means that your gut just kind of is in a shock state where it doesn't like anything, and it just, as soon as you eat something, it dumps it, okay? Treatment. Diet therapy, which were to reduce the jejunal osmolarity. Okay, so what does that mean? Low carbohydrate, high in fat and protein. Okay, I would know that. Okay, you will have patients who come to your clinic who have symptoms of dumping syndrome after post-op. Okay, you can, along with sending them back to their surgeon, start them on a very low carbohydrate diet that's high in fat and protein, and the majority of them within 3 months will subside. The majority of them will get better. Their gut will readjust, and they will start to be able to eat other things, okay? Sometimes it doesn't, but most of the time we can get it done. Okay, so we have a 62-year-old male who presents to the emergency department with a 6-hour history of sudden onset, severe abdominal pain. Okay, he reports a 3-month history of epigastric pain a few hours after meals, for which he's been taking over-the-counter antacids. His vital signs include a temperature of 100.5, pulse of 120, respiration rate of 22, blood pressure of 100/50. Is he sick?
Mm-hmm.
Yes,
Yeah.
he's sick. Okay. On exam, bowel sounds are absent. The abdomen is rigid with involuntary guarding. Plain film show air under the diaphragm, which is the most likely diagnosis. Who wants 1, 2, 3, 4, 5? Very good. It is perforated duodenal ulcer. What if it was esophageal? What do you think you'd see? Dysphagia, pain in the chest versus in the belly? Yep.
Wouldn't eat.
What's that?
Wouldn't eat. You wouldn't be eating. Like
Probably
you-
not, no. Okay. Okay, moving on to gastric cancer. Okay, again, this should all be review. Okay. Geographic variability. Okay, most common in Japan and China, but we've seen it all over now. Most frequently in males, peaks at around 70. Okay, when you have a chronic atrophic gastritis, associated intestinal metastases, or metaphasia. Yeah, this is all review. I'm not going to necessarily test on the upper part. Okay, but labs. What are we going to see? We can do an CBC. Okay, we're going to see anemia in about 40% of patients. This CEA, carcinoembryonic antigen. Okay, it's elevated in about 65% of patients. Okay. Something new is we can actually look for HER2, which is historically a breast cancer type of enzyme. But if that's positive, we can actually add trastuzumab, sure, with their chemo, and a lot of times it'll actually help. So that's a new thing. So HER2 is if you have metastatic disease and a positive H2, they can benefit from that med. Okay, what do? How do we find it? We do an upper GI endoscope with biopsies. It's gold standard. So EGD. Okay, diagnosis accuracy of 95%. So if we can see it, we can take biopsies of it, we'll find it. For staging, the TNM, does everybody know what TN, you've all heard that at least one time in the last 3 semesters. Okay, it's the tumor node and metastases. It's that big old scale, okay, big old chart, okay? So basically, what I want you to know is that if it's isolated to the mucosa, submucosa, okay, we can most likely just do, so that's a low tumor staging, low TNM, okay? We can most likely just do a mucosal resection endoscopically. If it is transmural, okay, if it has invaded through the wall and into, either just invaded through the wall or into other structures and metastasized, then we have to do a gastric resection with regional lymph node biopsies. Okay, and or we take the lymph nodes themselves. We don't necessarily do biopsies at that point, we do just take them. Okay, we'll still do that neoadjuvant chemo and radiation. If it is local, okay, most localized gastric cancer, surgical resection still remains the most potentially curative. It's localized. Okay, if at any point it becomes extensive, then we have to pretty much do a total gastrectomy. We may have to take the spleen, we may have to take part of the intestines, we may have to take whatever it's attached to, okay? And we do that with a thing called en bloc. Okay, we basically cut all around it and then take it out all as one. Okay? Alright. Small bowel obstruction. Okay? Lots of things cause small bowel obstructions. Most of the time in adults, it's adhesions from previous surgeries. If they've had previous abdominal surgery, most of the time, that is what's causing it. Okay? If they do not have previous surgeries, they may have a hernia, they may have tumors, they may have a volvulus, they may have something else going on. Okay? Again, acute obstipation, abdominal pain, distension, nausea, vomiting. We all saw this. We all talked about this when we did the acute abdomen. A small bowel obstruction may lead to an acute abdomen, okay? Some differentials, we talked about ileuses, okay? Pain is more diffuse, mildly, or more mild, most often in a post-operative setting, okay? Basically, remember what ileus is, it's a shock to the gut because we touched it and it just isn't moving, it's kind of sleeping, right? And it takes time to wake up. Gastric outlets or obstruction, okay? You may see a giant stomach full of air on x-rays, okay? Bunch of different things can cause a gastric outlet obstruction, which we'll kind of talk about, okay? Basically, treatment, adequate resuscitation is critical, okay? Even before we go to surgery, we really want to know, we really want to resuscitate them. So putting an NG tube to decompress the stomach, okay? Helps with nausea, vomiting. Depending on how bad it is, we may have to put in a urinary catheter to decompress the bladder. Okay? If they're really starting to become septic, that'll be important for ins and outs. We're going to do serial abdominal exams. Sometimes, or most of the time, they can resolve spontaneously. Okay, we help them through this episode. They don't perforate, and most of the time we can get them through, and then instead of doing an emergent surgery, we can plan for an elective surgery to try to do a lysis of adhesions or whatever in a more controlled environment. We can get them medically optimized. That is what we strive for. Doesn't happen all the time. Okay? So adhesions. So you have somebody who has prior abdominal surgery, intra-abdominal surgery. Okay? I've never really seen an adhesion in anybody that has not had abdominal surgery. Okay? You can kind of see here, like that's an adhesion. You have an adhesion here. Basically, tissue is stuck to another region. Okay? Anything below these are going to be compressed. Nothing can get through underneath. Okay? So adhesive bands that kinks the bowel, it prevents forward propulsion. Okay? It'll cause abdominal pain, distension, nausea, vomiting. Bowel sounds are still active though. It's still trying to move. That's what causes the pain. Okay? Your lumen before the obstruction will get nice, well not nice, it'll get super big, okay? Versus be full distal to it, it'll be kind of contracted, but your bowel is still trying to keep up. Okay? On x-ray, you'll see air fluid levels. Again, you want to admit, resuscitate, place on G-tube, and we want to watch for hypokalemic metabolic alkalosis, and fix those and correct those. Okay? Again, most resolve spontaneously, or we need to go to the OR for lysis and adhesions, cutting those bands so that it relieves that obstruction. Okay? Next, we have incarcerated hernias. Okay? Bowel herniates through abdominal wall, inguinal canal, wherever, and it's non-reducible. Okay? When it becomes strangulated, so incarcerated, it's just non-reducible, but bowel, there's still blood flow to the bowel. Once it becomes strangulated, that blood flow becomes affected, and you become ischemic, and that's when you can perforate. Okay? So any patient with unreducible hernias, pain, nausea, vomiting, need to resuscitate and schedule for surgery as soon as possible. Okay, we try to make it so we don't get to the strangulated part. Okay. Alright. Volvulus. We talked about this with acute abdomen as well. This is where it twists on itself. Okay? So closed loop volvulus. Basically you have a loop of bowel and it twists on itself at some point, and the middle that's twisted loses blood supply, as well as everything that's within that loop that's twisted. You know, there's a lot of bugs, a lot of weirdness inside our lumen, inside our gut, right? If it doesn't have anywhere to go, it's just going to kind of multiply and cause distension and infection, and not good. Okay? So if you have acute colicky, abdominal, massive distension, nausea, vomiting, this is where you have that. You may have pain out of proportion. It may look like or mimic ischemic mesenteric ischemia. Okay? But basically, We do either abdominal radiographs or CTs, okay, where it shows that transition point or where that contrast doesn't go further. Okay. Sigmoid volvulus is the most common, so that's lower left quadrant, okay, followed by cecum, which is the lower right quadrant. All right. Signs of systemic toxicity, okay, you'll have bloody rectal discharge, fever, leukocytosis, peritoneal irritation. Okay, if any of those things are present, we should probably go to the OR immediately to try to resolve it, okay, before it perforates. If you have peritoneal irritation, more than likely, though, it has perforated already. Okay, if those symptoms are not there, you should probably just do a sigmoidoscopy, at least initially. Okay, make sure that it is not within the colon. Okay. Colon volvulus proximal to the sigmoid should go to operation immediately. Now, first, I know that this slide mostly says a lot of colon and large bowel. This could happen in any part of the bowel. Okay? Any part of the bowel could twist on itself at any point. Okay? For small bowel, you'll still have those fluid air levels, you'll still have distension, you will still have other things that look like this, and basically if you have any of those, you're still going to go to the operating room to try to relieve it. Okay? What we want to try to prevent is perforation. Okay? All right. Internal hernias is another way that we can cause that small bowel to become an obstruction. Okay? Basically, we have a hole, or what we call a rent or a defect within the mesentery, and a slip or a loop of bowel, small bowel will kind of go through there. Very unlikely to be caused naturally, right? Most of the time we see them after traumas, high-speed motor vehicle accidents, and if there's a tear in the mesentery, tear in the bowel, and we don't necessarily see it. We really don't see these on CTs, okay? And we may not necessarily see it right off because, you know, once that the intestine goes through there, it's not really inflamed yet. Okay, so this is a couple days after after their accident. Then they start really having issues. Okay, we'll have to go in and actually either, depending on how bad that bowel has been damaged, either resect it and fix that mesentery opening. But we have to repair those mesentery defects. Okay, we really can't leave those because the risk of internal hernias and internal small bowel obstructions is pretty high. All right, now for a rare complication. Okay, so I know it says gallstone ileus. It's a little bit of a misnomer. It's not necessarily an ileus, it's actually an obstruction. Okay, when we have really big gallstones in our gallbladder, okay, that are heavy, basically the gallbladder will kind of sit on the small intestine and erode through the gallbladder wall, erode through the intestinal wall, and actually then block the small intestine lumen. Okay, so it's actually, so like on this picture right here on top, okay, you can actually see a distended bowel, small bowel proximal. You have the stone itself, and then distally, you have a nice, well not nice, but it's a tighter, non-distended bowel. So the obstruction is right here, and it's that huge S stone. Okay? So you have the Reigler triad. Okay? You're going to have pneumobilia, which is you do a CT scan of the liver, okay, and you actually have air up into the liver. Pneumobilia. Okay? You're going to have bowel obstruction signs, and you're going to see a gallstone within the bowel. Okay? That's the Reigler triad. On CT, we have that transition point of obstruction, the pneumobilia, and we can sometimes see that cholecystoenteric fistula. Okay? How do we fix it? We go in, we go and do a what's called a enterolithotomy. Okay, so it's like an enterotomy, proximal. Okay, we go into the bowel, we make a hole into the bowel, we get the stone out, and then we close up the hole. Okay. All right, Bezoars. Bezoars are fun, kind of. Foreign material in the GI tract. It can be anything. A lot of times we see it with trichotillomania when they eat their hair. Okay, it could be string, it could be with pica, it could be medications, it could be apparently milk. Never seen that. Okay, but anything that has too high of a fiber thing to really get our bowel to digest. Okay, it kind of just forms this ball of grossness, really compacted. Okay, and then it causes a small bowel obstruction. Okay? The only way to get that out is to, if it's higher up where we can reach it, say it's in the duodenum, you can do an endoscopy or an AGD to get it out, but anything that's further down, we have to do surgery. Just like with the gallstone ileus or the stone within the lumen, we go in, we find where the Bezoar is at, we cut behind it, we take out that Bezoar, and then we repair the defect. Okay, so this is pretty rare. All right, we already talked about the next 2 or 3 slides when we talked about acute abdomens and to talk about the type of differential diagnoses when we have acute abdomen. Okay, but when we have a baby, 4 to 6 weeks old, okay, they have progressive projectile non-bilious emesis. We always have to think of pylorus stenosis. Okay, on the side. Okay, we have to look for that severe dehydration, the hypochloremic, hypokalemic metabolic alkalosis. Okay, we have to do aggressive resuscitation and repletion of those electrolyte abnormalities. Okay, palpable olive pit. Okay, Pants loves to put in a 2-month-old with an olive pit, palpable olive pit in their epigastrium. That's what they like to do. Okay, we do an ultrasound to show the large pylorus with a narrow lumen. Surgical correction. Okay, we resuscitate them first, and then we do laparoscopic pylomyotomy. So basically, we put hammers in, we find the pylorus, we cut through the muscle. Okay, relieving that stricture, and we leave it open. Okay, most of the time, it will heal on its own. If we think that the area is really, what we can do too is close it. So if we cut down like the pylorus, right, we take the both ends and suture them together into the middle so that we're actually making the pylorus longer. Does that make sense? Kinda? Okay. Either way, just know that surgical correction with laparoscopic pylomyotomy is what we do. Okay? Intussusception, we already talked about this again. Telescoping of the small bowel, we have the current jelly stools. Okay? Target sign on ultrasound. Okay, this is what that looks like. Okay, again, Pants loves to use these types of things, so target sign on ultrasound. And what we do is barium enema is a diagnostic choice. Also reduces, most of the time, because we're putting fluid up into there, it'll actually reduce the intussusception. There really is no surgical fix for it, unless the barium enema does not work. Okay, Crohn's disease, we have the transmural inflammation of the GI tract. Okay, so Crohn's, right? It's not just colitis, it goes from mouth to anus. Okay, when we do the EGD, you'll see cobblesconing, you'll see skip lesions, it'll be transmural. Okay, meaning it can go all the way through that mucosa. Okay, normally treated with those drugs, but for surgical intervention, it is palliative. Okay, normally they have to have failed medical therapy, and a lot of times we're trying to fix the strictures that it causes from that scar tissue. Okay, and what we do is basically a strictureplasty We can either just excise the whole area, or we can make a longitudinal enterotomy over the stricture and then close it in that horizontal fashion like I told, like the chylomyotomy. Okay, so you make a longitudinal incision, take the two ends and put them together so that it's a longer scar in the opposite direction. You're basically, does that make sense? I don't know how to I may have to show you on a picture. We'll do that later. Anybody who doesn't understand what I'm saying, right after this class, I will show you kind of a better way to think about it. And then we drain for abscesses, okay? So that's the main surgical thing of what we do for Crohn's. We can either take out the areas that are having issues or try to fix them, and if there's an abscess, we will drain it. Okay, small bowel cancers, relatively rare, okay? If they're benign, they're mainly leiomyomas or adenomas. The most common malignant tumor is adenocarcinoma. Okay, if it's an endocrine type tumor, it's a carcinoid tumor. Okay, most benign will be asymptomatic. Malignancies will be symptomatic prior to diagnosis. Okay. If it's a carcinoid tumor, you may see actually carcinoid syndrome, hot flashes, bronchospasm, and arrhythmias. Okay. It's an uncommon source of obstruction in the small bowel. Imaging, we can see on CT. We can do this the pill cam, or the capsular endoscopy. Basically, we have the patient swallow this camera. It's a tiny little camera. And then we just follow the pictures all the way through, and then it goes out the other end. Okay. If found, we can do, so if we do either CT or either EGD or the capsular endoscopy, if we find anything abnormal, then we can do an EUS, which is that endoscopic ultrasound. Okay. We can do biopsies from that. We can see how the extent of the erosion is, okay, or invasion is. If it's adenocarcinoma, really depends, the extent of the surgical resection really depends on location and the depth. Okay? If it's a carcinoma, we do radical surgical excision, depending on where that carcinoid tumor is. So 40% of the midgut carcinoma tumors will be associated with a secondary malignancy. Okay, so if you find a carcinoma or a carcinoid tumor in the midgut, you have to be looking for that secondary GI malignancy. Okay, don't miss that. All right, we have a 35-year-old woman presenting with symptoms of acute bowel obstruction. Her past surgical history is significant for a total abdominal hysterectomy with bilateral sphingolo-oophorectomy 3 years previously. Which of the following is most likely present and best explains these findings in this patient? Who wants one? 2, 3, 4, 5. Okay, yeah, so it's adhesive intestinal bands. So she had an abdominal hysterectomy, which means they went in through her belly. Okay. It doesn't matter what they had done, but she had abdominal surgery. So most likely her cause is adhesion. Okay. All right, primary care responsibilities. If these show up to your clinic, what are the main things? This is not all inclusive. This is just kind of I went through PowerPoint and was like, what do I really want you guys to know when you go to primary care? Okay, this does not include ER. This is just primary care. Okay, do a complete history and physical. History is important, right? If they come to you and you don't ask certain things about, they're having dyspepsia or dysphagia, and you don't ever elicit that fact that they drank bleach as a kid, you're probably never gonna, you may get to the point where they have strictures, but it'll take you a lot longer. Okay? GERD. Know the guidelines and when to refer to sternal surgery for an EGD. Okay? Which is what?
2 PPI failures.
So failure of PPI after how long? After 8 weeks. Okay? You send a patient who's just started, this is their first diagnosis of GERD, okay, and they just started a PPI, and it's only been 2 weeks. One thing that you could do is test for that ZES. If it's positive, if that serum fasting gastrin is elevated, if it's high, then send to general surgery, okay? But if that's negative and there's no other real signs, you have to give that BPI a chance to work, okay? You may need to go up to a double dose, a 2-day dose, 2 dose a day, okay, for that 8 weeks. If it doesn't work or their symptoms return after they stop that medication, that's when we need to do an EGD. These patients, your patients, especially the ones you inherit, should not be on a PPI for more than 8 weeks without an EGD. Okay, if they come to you and they've been on a PPI for years and they've never had an EGD before, send them to general surgery. They need to have it done. Because most of the time, if they're needing that much for that long a period, there's something else going on, and most likely either there's something else going on or we're missing their esophageal cancer, okay? Because they're relying on that PPI to keep their symptoms in control. And that will happen. You will show up to your first duty station and you're gonna inherit these patients and be like, yeah, I'm just here for my PPI refill. It's like, well, how long have you been on it? Oh, years, 10 years. Have you ever had an EGD? I don't know. Send them either to GI or to general surgery. Okay, that is an absolutely appropriate referral. Okay, any and all foreign bodies in the esophagus go to the ED. Okay, if it's a button battery, give the ED a heads up. Most likely, they will have called general surgery or GI and they will have brought the scope down and be ready. Okay, know your patient's history. Like I said before, with number 1, corrosive esophagus may have complications for the rest of their life. So if you don't know what their history is, you can't help them. Okay? PUD, if you suspect an ulcer, don't sit on it. Refer to general surgery. Okay? So if that GERD is so bad that they've caused PUD, send them to general surgery for an EGD and biopsies. We've got to figure out why they're having ulcers. Okay? Lots of things can cause small bowel obstructions. Okay, we just went through like 10 of them. Know the signs and send to ED. Okay, even with a partial or a pseudo small bowel obstruction, most of the time you need to be admitted in the hospital to watch to make sure that they don't go to a complete small bowel obstruction. Okay, so anybody who has any signs of a small bowel obstruction, pseudo small bowel obstruction, whatever, you need to send them to the ED, and most of the time they will get admitted. Okay. Crohn's, UC patients need to be referred to GI for follow-on care. Okay. You, as a PCM, can help manage it, but diagnosis and treatment should start with a GI specialist. That's not Gen Surg. Gen Surg only gets involved when we need to take stuff out. Okay. When they have a stricture, when they have an ulcer that's bleeding. Okay. So if you have a patient, just like with GERD, they've had a diagnosis of Crohn's or UC, they should have been seen by a GI specialist who is actually managing and changing their doses of any medication that they are on. Okay? You can write refills if they are stable, okay? But you as a primary care provider should not be making these diagnoses because we have to have that EGD and that view of that skip lesions, those cobblestonings. We have to take biopsies to make sure that it's not cancer or any other thing that's causing it, okay? So, those are my big takeaways. Any questions? Did you get done early? 3 minutes early, I did too. I was really worried we weren't going to get through this. Any questions on small bowel, stomach? Do you guys want me to just draw out real quick what I mean? With that longitudinal thing. Okay. So I don't know if you can all see this. I know it's real small. You can come up here and kind of look at it later, okay? So if we have a stricture, okay, we're going to make a longitudinal cut, okay?